focused on diabetes mellitus, thyroid disorders, and adrenal disorders, with 4 answer choices and detailed explanations. Endocrinology, clinical vignettes, diabetes, thyroid, adrenal disorders. 1. Type 1 diabetes mellitus, autoimmune destruction. A 12-year-old boy presents with polyuria, polydipsia, weight loss, and fatigue. Labs show hyperglycemia, ketonemia, and an anion gap metabolic acidosis. What is the most likely pathophysiology? A. Insulin resistance. B. Pancreatic beta cell destruction. C. Increased glucagon secretion. D. Defective insulin receptor signaling. Answer B. Pancreatic beta cell destruction. Explanation. Type 1 diabetes mellitus, T1DM, is caused by autoimmune destruction of pancreatic beta cells, leading to absolute insulin deficiency, hyperglycemia, and diabetic ketoacidosis, DKA. 2. Diabetic ketoacidosis, DKA. Emergency management. A 22-year-old man with type 1 diabetes mellitus presents with vomiting, deep labored breathing, and confusion. Labs, glucose 450 milligram, pH 7.15, bicarbonate 12 millimicromolar, ketones positive. What is the first step in management? IV insulin, B. IV fluids, C. IV potassium, D. Sodium bicarbonate. Answer B. IV fluids. In DKA, the first step is IV fluid resuscitation to correct hypovolemia. IV insulin follows to lower blood glucose, and potassium must be replaced once insulin therapy begins. 3. Hypoglycemia in a type 2 diabetic on insulin. A 65-year-old man with type 2 diabetes mellitus on insulin therapy is found unconscious with glucose 40 milligrams per deciliter. What is the best next step? A. Administer glucagon IM. B. Start IV normal saline. C. Give IV dextrose. D. Check C-peptide levels. Answer C. Give IV dextrose. Explanation. Severe hypoglycemia requires immediate IV dextrose. Glucagon is used if IV access is unavailable. Checking C-peptide levels helps differentiate endogenous versus exogenous insulin sources. 4. Hyperthyroidism, Graves' disease. A 33-year-old woman presents with weight loss, heat intolerance, palpitations, and exophthalmos. Labs, low TSH, high free T4. What is the most likely diagnosis? A. Toxic multinodular goiter. B. Graves' disease. C. Hashimoto's thyroiditis. D. Pituitary adenoma. Answer. Explanation. Graves' disease is an autoimmune disorder with TSH receptor antibodies causing thyroid hormone overproduction. Exophthalmos is unique to Graves' disease. Thyroid storm, life-threatening hyperthyroidism. A 45-year-old woman with untreated hyperthyroidism develops fever, tachycardia, agitation, and altered mental status after surgery. What is the best immediate treatment? A. Methimazole. B. Levothyroxine. D. Radioactive iodine. Explanation. Thyroid storm is a medical emergency. Beta blockers, e.g. propranolol, control tachycardia. PTU, propylthiouracil, inhibits new hormone synthesis, and corticosteroids reduce T4 to T3 conversion. Hypothyroidism. Hashimoto's thyroiditis. A 50-year-old woman presents with fatigue, weight gain, dry skin, and bradycardia. Labs, high TSH, low free T4, positive anti-TPO antibodies. What is the most likely diagnosis? A. Graves' disease. B. Hashimoto's thyroiditis. C. Euthyroid 6 syndrome. D. Subacute thyroiditis. Answer B. Hashimoto's thyroiditis. Explanation. Hashimoto's thyroiditis is an autoimmune disease causing hypothyroidism. Antithyroid peroxidase, anti-TPO antibodies are present. Levothyroxine is the treatment. 7. Primary adrenal insufficiency, Addison's disease. A 40-year-old man presents with fatigue, weight loss, skin hyperpigmentation, and hypotension. Labs, low sodium, high potassium, and low cortisol. What is the best diagnostic test? A. Serum ACTH. B. Concentropin ACTH stimulation test. C. Renin and aldosterone levels. D. Dexamethasone suppression test. Answer. Concentropin stimulation test. Explanation. Addison's disease primary adrenal insufficiency is due to adrenal gland destruction, e.g. autoimmune or TB. Concentropin H test shows minimal cortisol response. Secondary adrenal insufficiency. Pituitary dysfunction. A 55-year-old man with a history of chronic steroid use presents with fatigue, weakness, and hypotension. Labs, low cortisol, low ACTH, normal aldosterone. What is the most likely cause? A. Adrenal gland destruction. B. Pituitary ACTH deficiency. C. Hyperaldosteronism. D. Addison's disease. Answer B, pituitary ACTH deficiency. Explanation: chronic glucocorticoid use suppresses ACTH from the pituitary, leading to secondary adrenal insufficiency. Unlike Addison's, aldosterone remains normal. 9. Cushing syndrome, ACTH-dependent hypertension. A 48-year-old woman presents with central obesity, purple striae, hypertension, and muscle weakness. Labs show elevated cortisol and ACT. What is the best next step? A. Low-dose dexamethasone test. B. High-dose dexamethasone suppression test. C. MRI of the pituitary. D. Adrenal CT. Answer B. High-dose dexamethasone suppression test. Explanation: ACTH-dependent Cushing syndrome, e.g., pituitary adenoma versus ectopic ACTH, requires a high-dose dexamethasone test. Suppression suggests Cushing's disease pituitary, while no suppression suggests ectopic ACTH production. 10. Pheochromocytoma catecholamine excess. A 35-year-old woman presents with episodic headaches, palpitations, and severe hypertension. Labs show elevated plasma metanephrines. What is the best preoperative medication? A. Beta blockers. B. Alpha blockers. C. Calcium channel blockers. D. ACE inhibitors. Answer B. Alpha blockers. Explanation: pheochromocytoma is a catecholamine-secreting tumor. Alpha blockers, phenoxybenzamine, are given first to prevent hypertensive crisis. Beta blockers are added later to control tachycardia. Key takeaways for diabetes, thyroid, and adrenal disorders. T1DM, autoimmune beta cell destruction, absolute insulin deficiency. DKA treatment, IV fluids, insulin potassium. Graves' disease, autoimmune TSH receptor antibodies, low TSH, high free T4. Thyroid storm treatment, beta blockers, PTU, steroids. Addison's disease, primary adrenal insufficiency, low cortisol, high ACTH, hyperpigmentation. Cushing's disease, pituitary ACTH overproduction, high-dose dexamethasone suppression test. Pheochromocytoma, episodic HTN headaches, palpitations. Alpha blockers, phenoxybenzamine, before surgery. Would you like clinical vignettes